Assalamu alaikum. Welcome everyone on board. I just found this text. We started the discussion about liver. So we covered almost major part of the liver anesthesia and how to evaluate a patient. So I just found this very quickly. We will just try to have a look again. So like these are general s- uh, symptoms which you can find in a patient with liver liver disease like anorexia, malaise, weight loss, bruising, itching, right upper quadrant pain, fatigue, fever, dyspepsia, melena, dyspnea, orthodoxia, polytopnia, hematemesis, GI, upper rectal, upper GI, lower GI bleed, history of blood transfusion, sexual history, alcohol abuse, ICU admissions, ventilator history, and the normal metabolic equivalents, comorbids. Uh, okay. So any past surgical, past anesthetic history, family history, infectious disease history, and then drug history with all other things. But usually with liver failure, patient may be taking beta blockers to reduce portal hypertension, octreotide, also potassium sparing because of high levels of aldosterone in these patients. Okay, so in examination, there is anemia, jaundice, clubbing, chylomicronemia, muscle wasting, palmar erythema, caput medusae, gynecomastia. We discussed actually yesterday testicular atrophy. This is a good actually revision. In a palpation, there may be hepatosplenomegaly, uh, this ascites, uh, okay, liver span, maybe liver not maybe palpable if there is too much ascites, uh, pleural effusion, shifting dullness, fluid thrill. Okay, so investigation mainly will be synthetic function and obstructive problem and other evaluation with the other disease, other systemic effects of liver disease. Actually, we just discussed, and as we yesterday we discussed that we will classify on the basis of child pox score, that how severe is the disease, and we will uh, reverse accordingly. If it is C, we will try to push on B. If it is B, we will try to push on A. And in addition to like monitoring the standard one, standard two monitoring, and additional will be like uh, this one intra-arterial blood pressure monitoring, EBGs, temperature, neuromuscular blockade, urine output. Large bore IV cannulas is mandatory. Rapid infusion system. Uh, it's a good one. It's in the okay. So okay. So some words about acute. There was another article. So acute liver failure, uh, as we discussed yesterday as well. Paracetamol, hepatitis E, hepatitis A, okay, and then uh, acute liver failure may be further classified according to the time interval between the onset of jaundice and development of hepatic encephalopathy. Okay, so hyperacute within 7 days of joint half within eight. What is HE? This is because something new for me. Hyperacute liver failure, acute liver failure, and subacute liver failure. So less than 7 days, 8 to 28 days, and up to 12 weeks. So, and the common things are paracetamol, chemotherapy, statins, carbamazepine, fluoxetine, anti-tuberculous drugs, anti-epileptics. Okay. And then viral cause listed in table one. Here is the table one. Mhm. Cannot see. Yes, this one. Hepatitis A, hepatitis B, hepatitis C, Epstein-Barr virus, herpes simplex, varicella zoster, HIV. So, okay. So, preeclampsia can also cause this HELP syndrome, fatty liver of pregnancy, vascular, this hypoxic hepatitis, Budd-Chiari syndrome, uh, Wilson's disease, malignancy, autoimmune, hemophagocytic lymphohistiocytosis. These are uh, what do you think? What will be the Pfizer? Uh, can you tell what will be the management strategies in patient with acute liver failure? Yes, Pfizer, would you like to see?
Sir, I think first we have to start from ABCDE management.
Very
Then
good.
we'll find the cause and treat accordingly. Then third is sir, acute liver failure. It has some scores, and according to score, then we can shift the patient for liver transplant unit.
No, no,
Refer the
actually,
patient.
oh, okay, fine. So what is can you tell me the name of that score?
No, sir, I completely forgot it.
This is King's College. Okay. So, but actually there is no specific management. Okay. And it will be supportive management, like patient can develop jaundice, patient can develop like nausea, vomiting. So you see as you mentioned, airway, breathing, circulation approach. And you see here it's written here, so early elective tracheal intubation with encephalopathy. So things will be related to encephalopathy. And then you see aspiration prophylaxis, if it is encephalopathy, like strategies with reference to intracranial pressure. Okay. ICP, then if mechanical ventilation, all the ventilator bundles. So prevention of ARDS, because if these patients, it is also a trigger for ARDS. Okay. And systemic, because in liver failure, systemic vascular resistance will be low. So there we may be, so you might have to treat on the base on the lines of septic shock management. Okay. So the same step, fluid, vasopressor, then dobutamine, steroid. So the same lines of shock will you will be doing. Uh, okay, what else? Albumin replacement. If it is coagulopathy, then coagulation, sorry, FFPs, or uh, this cryoprecipitate, or uh, this PCCs. Okay. And then you have to prevent the other organs. Acute kidney injury can occur, okay, because of hypoperfusion. And so acute liver failure secondary to uh, paracetamol poisoning. We will discuss about paracetamol poisoning as well. So you see, older age, paracetamol induce acute liver failure, hypotension, SIRS, infections. Actually, I tell you something. There is nothing specific. These are general care which will be there in any cases wherever there is hypoperfusion of kidneys, hypovolemia, the same things will be here. Yes, of course, there will be certain predisposing factors. Already, if patient has some renal impairment, so that patient will go in according how we classify the acute renal failure. Yes, Faiza, or any exam candidate. Very simple. Rifle or akin. Okay. So,
Yes, sir.
okay. And just what will be the difference between CRRT and dialysis? Main difference.
Sir, one is intermittent hemodialysis and other is continuous renal replacement therapy.
This is not the correct point. Usually,
One is, yes,
yes, CRRT will be preferred in which patient groups?
hemodynamically unstable patient, and CRRT is done in a specialized unit, specialized centers.
Not specialized centers. In any ICU, RRT can be proceeded. Usually, it is for longer time. Okay, and it is better tolerated by patients with hemodynamic instability. Okay, hemodialysis will not be as good tolerated as compared to RRT. Okay, so uh, you see hyperammonemia, sodium imbalance, temperature, and metabolic control is preferred to prevent cerebral complications related to fluid shifts. Refractory hyperammonemia is shown to respond to higher intensity ultrafiltration with rates up to 60 to 90 ml. This is specific main issues, but related to, we will discuss inshallah this renal replacement therapy dialysis separately. So up till now, you see, acute liver failure causes, how to identify probable cause. There may be acute on chronic, then there may be some drugs, some viral infections, some toxins, as we discussed, paracetamol, alcoholism. So there are so many things. So treatment according to the cause will be one of them, and this generalized management will be on one side. So if it is encephalopathy, airway we may be secured, and all the concerns with reference to ICP. Okay. So there are a number of problems associated with, like ammonia. It lead to astrocyte swelling, mitochondrial dysfunction, cerebral edema. Okay. So there will be like midline shift or all the things related to it. What else? Mm, like these are actually generalized thing again. Reducing cerebral oxygen consumption, adequate sedation, maintaining normocapnia, normoglycemia, minimizing venous congestion, head elevation, loosening endotracheal ties, avoiding hyperthermia. Okay, and minimizing like serum maintain between 145 to 150. This I doubt. I don't know what's the reason for it. And continuous infusion of sodium chloride. This is wrong. This is not 30%. It's 3%. This is a hypertonic saline. This is wrong. Corrected. Cannot be 30%. Uh, okay. So coagulation, as we like INR, thrombocytopenia, and reduce circulating pro and anticoagulant proteins, fibrinogen concentration. So, because actually, if invasive procedures are to be done, this is something else. But main problem, when the risk of spontaneous bleeding can also be there. Okay. Uh, okay. So, as I mentioned, these words you listen from me a number of times. Point of care testings, thromboelastography, rotam, INR. Okay. What else? Mm, Okay, so like you see, they can ask you about these questions, that how much should be the level. So around 100,000 for elective procedures, and you see, for intravascular catheters, around more than, actually these you will find in different books, different ones. So I think, in my concept, it should be around 50,000, not 30,000. 30,000 is too low. Uh, so don't be confused. Follow one one point. Don't take words from everywhere. Okay. uh, Okay, so sepsis, all the things related to sepsis, like taking the cultures, it's starting empirical antibiotic, fluid management, and all everything. Okay. Prophylactic use of antibiotics because these patients can like have if it is related to ascites, so it may bacterial peritonitis can also occur. Okay, and hypoglycemia is frequently present in patient with ALF, so you have to maintain the blood sugar, but at the same time, don't cause hyperglycemia because hyperglycemia is also not good. Okay. Derangements of magnesium, calcium, potassium, phosphate are frequently observed. Okay, so actually, N-acetylcysteine is more specific to paracetamol poisoning. Okay, so can you tell me few words about paracetamol poisoning, how it occurs? What the main point? Anyone wants to speak out? Faiza or anyone? Iqra? Actually, this NAPQ, NAPQ, okay, this is a toxic product which is normally dealt with this glutathione. Okay, uh, when there is overwhelm, like if the patient is taking too much paracetamol, this NAPQ will not be dealt with. So that will cause hepatotoxicity. Okay. So when we give N-acetylcysteine, actually it provides cysteine, which is a precursor for glutathione. So that's the mechanism which occur. And this was the one which I was telling you, King's College criteria for liver transplant. And there is another model which for liver transplant, which is there mainly in chronic liver disease. What is the name for that? That's MELD, and for pediatric it is PELD, model for end stage liver disease and pediatric end stage liver disease. If I'm not wrong, a PELD, what does, I think it's the same, is like that. So if it is like pH less than 7.25 and lactate more than 3 and prothrombin time more than 100, creatinine more than 300, a grade 3 or 4 hepatic encephalopathy. Okay. So if it is not sorry, not related to paracetamol, then there are some other things which are one of them is increased PT and any of three, like age less than 10 or more than 40, seronegative or drug induced ALF, jaundice to encapsulo more than 7 days, PT more than 50, and bilirubin. These are just criterias, but like you just need to know the parameters because it's not possible to remember all the numbers and everything. So if you forget, or at least try to remember the parameters name if you don't remember the numbers. Okay. So like encephalopathy, creatinine, and PT here, and age and this bilirubin. So you can just cram like that. Okay. Mm. So penicillamine, chelating agent with reference to Wilson's disease. Plasma exchange, I don't know, for plasma exchange for autoimmune problems. Okay. So if there are high level of antibodies, uh, plasma exchange may be done. So let's see. There is actually one more article on liver, acute liver failure. Just a second. Okay. So actually, this is another article on acute liver failure. We have almost discussed. There will be jaundice, there will be hyperimmunemia, which is causing especially the brain and kidneys. Okay. And then hepatic encephalopathy and related to ICP, third problem, and shock. Okay. So because of SVR, because of intravascular volume depletion, edema, Um, Again, quick revision. So viral viruses, you know, herpes simplex, cytomegalovirus, varicella zoster, Epstein-Barr virus. I don't know what is this DENV. And then toxins, mushroom, venoclusive, Budd Chiari syndrome. You should know common, which you can. Anesthesia related, of course, now we don't use halothane, but it is halothane is one of the factor. Wilson's disease. You see, they have put a very good like main specific treatment for paracetamol. It's N-acetyl. For hepatitis, antiviral lamivudine. Okay, ganciclovir. This you can just for mushroom there is activated charcoal. Amanita, this penicillin G. Okay, Budd-Chiari syndrome, anticoagulation, thrombolysis, thrombectomy, portal vein thrombosis. Okay, and then acute ischemic injury. Okay, Wilson's, we saw before, specific this plasma exchange. Okay, then okay, with pregnancy, delivery of the baby. See, HELP syndrome, delivery of the baby. Preeclamptic liver rupture, surgical hemorrhage. This is uncommon. Don't, please, when they start asking you, don't tell this. If they are putting pistol on your head, rifle on your head, only say these words. Otherwise, don't try to recall these words. I feel vomited when these difficult things come. I never try to memorize each and everything. Okay, so hemophagocytic lymphohistiocytosis. You yourself will feel nausea. So we discuss about it. Coagulation factor 2719, rotum. This one, hypoglycemia, sepsis. Okay, so what is this? Please, very simple. Okay, just encephalopathy grades. Don't uh, try to like too much difficult way. Try to remember in a very simple way. Okay. What else? Acute kidney injury, metabolic acidosis, hyperlactatemia. Okay. How to lung protective strategies if needed. Like, okay. Any comments? Anyone wants to add something? You see, vasodilatory shock, and then the same thing you can tell. Uh, Monitor the intraarterial blood pressure monitoring, cardiac output monitoring. Okay, fluid bolus, goal-directed fluid therapy, repeated ABGs, correction of air electrolytes carefully. These are the things which you have to tell. Okay. The response to fluid therapy must be assessed clinically and biochemically with care taken to avoid hyponatremia, which can worsen cerebral edema, as well as hyperchloremia, which is associated with renal failure. So these are the things which you have to take care. If you forget, you can use this word, uh, careful titrated correction of the electrolytes. So this will cover everything. Okay. Mm, ICP monitoring, they've told. I don't find anything very special. NG tube will be placed carefully, and if there is GI complications, then they can consider TPN. Otherwise, whenever possible, it's better to have enteral nutrition. Okay. Uh, it's very nice. Actually, we don't have these articles when we used to study. Believe me, it's so nicely placed. You can recall the charts and see, you can see how nicely it is written. And okay, so I think this is enough for this topic. Another thing, people just get afraid that how to read all the articles. You don't need to read all the articles. If you understand, you just enumerate, especially if you are appearing in an oral exam, it's very easy. Just make a summary, very big, like frank summary, I would say. Just take the main points. Like up till now, if you just recall, you will have some symptoms, you will have some causes. They will ask you how to manage. So now you can, if even if, because I am just telling you, repeating the words, so you will have a concept that in this patient encephalopathy can occur, so you have to take care of it, take care of ICP, take care of fluid, intravascular fluid volume. As there will be vasodilatation, so you are needing to give vasopressors. So you have to avoid the factors which can further deteriorate the neurological outcome. You might need renal replacement therapy. You have to treat on the lines of sepsis. There are some specific causes of liver failure you will be taking care. Patient can go in hypoglycemia, so you have to take care. So I don't think so it is okay. What is the fluid of choice for acute liver failure with heart failure and portal hypertension, ascites, crystalloids? Actually, Jinan, the thing is that there is no single word answer. You have to be careful. First of all, you have to monitor the volume status. So, and parameters you can follow is the intra-arterial blood pressure monitoring, or cardiac output monitor. This will tell you the fluid status. Then choice. If you have hypoalbuminemia, so it's better to give colloids, because it will correct. And then electrolytes according to the situation. If sodium is low, you will prefer not, so, of course, 0.9% normal saline. Okay. Otherwise, you can give ringer lactate. There is no single word answer. You have to you can say the approach will be individualized. Okay. Like if it is heart failure and you have to maintain the intravascular fluid volume, so it's always better to give some combination of colloids and crystalloids. Okay. So I think that should be the answer. Okay. So hepatorenal syndrome. So we will uh, okay. Anyone was raising? Yes, Dinesh, you want to ask something? Okay. Hmm. So we will just have a look on this hepatorenal syndrome. Okay. So renal failure in common in, if albumin is low, which fluid to give? Can you repeat, please? It will be albumin, 5% albumin. Okay. Actually, in Pakistan, it's not commonly available, but like where we are working in Saudi Arabia, albumin is freely available. So actually, albumin is among the colloids. It's the safest among the colloids. Uh, Even we are giving it as a volume replacement. If we want to give, for example, some intravascular volume in a patients with limited cardiac reserve, or in old age, or anything in which you are have any doubt of leaky capillaries and the patient can go in pulmonary edema. So I always prefer to give albumin. Like for example, you are deflating, suddenly their abdomen will be deflated and the patient can have sudden hypotension, like 250 ml or 500 ml of albumin will support this and the blood pressure will not fall down. So that's what we do. Okay. Okay, so some of the causes of renal failure in a patient with the cirrhotic patient or liver failure patient. So one of them is ATN. Okay. Uh, Clues are found in the history. Urine analysis make urine concentration, urinary sodium less than 10, and FeNA less than, fraction excretion of sodium will be less than 1%. Okay. Because It's different between the acute renal failure and the chronic renal failure. So, pre-renal, variceal or gastrointestinal bleeding, sepsis, and diuretic treatment for ascites predisposed to hypovolemia and pre. So, the third commonest cause of renal failure in cirrhotic discussed below in detail. So, there are certain uh, 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 renal toxic medications. So, aminoglycosides, NSAIDs, diuretics itself, ACE inhibitors. Okay, so there may be some glomerulonephritis, IgA nephropathy, vasculitis, post-renal because of obstruction. So hepatorenal syndrome. So it's a diagnosis of exclusion. So criteria is major criteria, chronic or acute liver disease with advanced hepatic failure and portal hypertension. This is criteria number one. Okay. Then low GFR as indicated by serum creatinine more. This is 133 is actually 1.5. It's 88. 88 is 1 milligram per DL. Okay. And so 133 is around more than 1.5. Or 24-hour urine creatinine clearance less than 40 mLs per minute. Absence of shock, ongoing bacterial infection, and recurrent or recent treatment with nephrotoxic drugs. Okay. Absence of GI fluid losses or renal fluid losses. No sustained improvement in renal function following diuretic withdrawal and plasma expansion with 1.5 liter of isotonic saline. Proteinuria less than 500 milligram per day and no ultrasonic evidence of obstructive uropathy. Actually, you can say that in the absence of the uh, uh, other predisposing factor, if renal failure occurs in a patient with cirrhosis, that will be labeled as hepatorenal syndrome. So there are certain other indices with urinary volume, urinary sodium, osmolality, RBC, and then what is yes, cirrhosis with the ascites, creatinine more than 1.5, absence of shock, absence of hypovolemia, okay, no nephrotoxic drug, no parenchymal renal disease. I think this is better, easy to recall. Okay, uh, no parenchymal renal disease, normal ultrasound on urinary sediments. Uh, Despite these criteria, HRS is frequently misdiagnosed. Distinguishing between HRS and both pre-renal and ATN can be difficult. In case of pre-renal failure, the urine chemistry is similar and it is failure to improve with volume expansion, which is hallmark of hepatorenal syndrome. Like in AKI or other than this HRS, the patient will respond to fluid. But here, it will not respond to fluid therapy. Okay. While fractional FeNA is normally more than 2 in ATN, it is less than 1% in the setting of renal ischemia and cirrhosis. Granular, I don't have very good concept of it. Like it's totally cramming stuff. But usually, if they are asking you hepatorenal syndrome, I think if you have this knowledge of this chart, I think it's more than enough. Then further subdivision into type 1 and type 2. I never able to swallow it. Cirrhosis and rapidly progressive renal failure. This rapidly progressive renal failure causes doubling of creatinine in less than 2 weeks. It may arise spontaneously or in association with treated SVP, and usually accompanied by rapid deterioration of liver function. Okay, and then type 2 cirrhosis and subacute renal failure. This type is characterized by stepwise deterioration of renal function over a longer time period, often in patients with refractory ascites. Um, this is too much. So pathophysiology, we will just try to have a look at it. Okay. Splenectomic circulation of cirrhotic liver is dilated due to mediators, including like there are too much vasodilators. Okay, which are overproduced by vascular endothelium in splanchnic and portal circulation and not metabolized by cirrhotic liver. Okay, with portal systemic connections. This lead to reduced SVR. This is interpreted in turn by JG apparatus as effective hypovolemia because there will be vasodilatation to decrease renal perfusion. So it will be if in the JG apparatus it is as hypovolemia. and the sympathetic nervous system and renin-angiotensin is activated, leading to increased renal vasoconstriction. ADH is activated, giving rise to hyponatremia, and ascites is associated with cirrhosis. Okay. In extreme instances, acute cortical necrosis due to renal artery vasoconstriction can occur. The cardiac output in HRS was traditionally felt to be high, but recent thinking put cardiac dysfunction on a background of cirrhosis as an important trigger of HRS, is so-called cirrhotic cardiomyopathy. Okay? Uh, it's very difficult. I don't know how to explain to you, but usually you can say that it's over response of what is happening in liver failure because there is effective a decrease in effective circulatory volume. So kidneys are responding in a bad way. So that's what is happening. So risk factor for hepatorenal syndrome will be like spontaneous bacterial peritonitis, alcoholic hepatitis, hence diuretic resistant ascites, especially after paracentesis, recent variceal bleed, severe hyponatremia, MELD score more than 18. So presentation, the patient who have recent surgery, GI bleed, acute hepatitis, rising creatinine despite adequate volume restoration or treated SBP up to 25% of SBP causes HRS. So there is no specific treatment. There is volume restoration by giving some discontinuation of diuretics and volume expansion with albumin and followed by 20 to 40 gram per day directed towards appropriate cardiac endpoints in combination with vasoconstriction. So you have to replace the fluid with the albumin, and you have to stop the diuretics. And because there will be vasodilatation, so you have to give some vasopressors. CVP monitoring, cardiac output is actually now is a better indicator parameter than CVP. A patient taking chronic beta blocker therapy for control generally have these discontinued. Albumin is preferred. Okay. Systemic vasoconstriction. Terlipressin is powerful vasopressin agonist, which they are using. What else? RRT may be needed. And TIPS, transjugular intrahepatic photosystemic shunt. It's least likely that they will be asking hepatorenal syndrome separately. So this will be coming just in between the discussion. So we are just having a look. So I don't think so. Hepatorenal syndrome will be asked in as a separate table viva topic. I think it's enough for today. So it's a boring. I don't like topics which has too much cramming. So it's against my personality, unfortunately, because I try to clear my concept. So this is maximum I could reproduce. So okay, tomorrow, inshallah, we will try to have alcoholic liver disease. That's what I was thinking. Okay, so thank you very much. Sorry for I do because I don't have a trick to make this specific part of liver interesting. Okay. So thank you very much. Inshallah, we will do alcoholic liver disease tomorrow. Bye bye.